So it's 12:02 right now. So welcome everyone. Thank you for joining us today. My name is Dini Arsono. I work at CIRA. I'm Assistant Director of the Clinical and Health Services Research Core. And welcome to today's talk, titled Lessons Learned from Using the Data to Care Approach for Improving the HIV Care Continuum in Connecticut. So today's seminar is being recorded for future viewing. Presentation slides and recording will be available at CIRA website. If you are new to CIRA, welcome. And I would recommend to signing up to CIRA e-bulletin, a newsletter that we have full of information and resources on events, funding opportunities, including peer review opportunities for CIRA affiliates, pilot projects, and other programs that we provide to support our researchers. And as a reminder, we have the next sort of like CIRA organized event will be the qualitative research discussion group moderated by by Dr. Loretta Grau, and is going to focus on using adaptive analysis or how a community of practice led to improvements in TB care in Uganda. And that's going to be on June 18th, Friday at noon to 1:30. And I will post the link to signing up and details to this event after the introduction. So today's talk will be moderated by Dr. Jennifer Edelman. She's at the School of Medicine and School of Public Health, and also the director of CIRA's Clinical and Health Services Research Core. The presentation by Dr. Villanueva will be followed by a discussion and Q&A session. And we would like to invite everyone attending today to please use the chat to submit your questions and comments, and to also engage with other participants. And with that, I will pass the floor to Jen. Thank you.
Thank you, Dini. Welcome, everybody. Dini, thank you so much for organizing this. And I'm thrilled to welcome Dr. Villanueva and hear her talk. For those of you who don't know Dr. Villanueva, she's director of the HIV/AIDS program here and runs the program for our region. She is an outstanding infectious disease physician and an educator, outstanding clinician, and really has been leading the way in using the Ryan White CareWare data to help inform care and leading exciting initiatives with the health department to promote Hep C treatment in different settings. And we'll be talking to us today about where we are. So thank you, Dr. Villanueva, for doing this. We're so excited.
Well, thank you very much for inviting me to speak here. I was telling Jen that, you know, it's always a great opportunity for me to review the data that I have and to kind of gain perspective, because one can lose one's way when you're always looking at your own data. But when you're presented to other people, you start to say, this makes sense. So I am going to go ahead. Let's see, let's make this a slideshow. There we go. Okay, so the title of my talk today is Lessons Learned from Using the Data to Care Approach for Improving the HIV Care Continuum in Connecticut. So my objectives today are, for those who are not familiar with this strategy, to discuss really the pillars of the strategy, to discuss our CDC grant, which was called the Cooperative Re-engagement Clinical Trial. And I want to talk about our results here in Connecticut and our results from the multi-sites. And then finally, start to ponder as to what our lessons learned were. Okay. Okay, so first of all, where did data to care come from? So this was actually an article that was written in 2013 by Patricia Sweeney, who was at the CDC, and she entitled it, Shifting the Paradigm, Using HIV Surveillance Data as a Foundation for Improving HIV Care and Preventing HIV Infection. And at the time, it was sort of revolutionary to think that people from health departments were very into their surveillance data could actually dip their toes into the care arena and actually get out of their sort of surveillance mindset and use their surveillance data to actually help people in the clinical realm and people in the prevention realm. And so this was really the basis from which data to care efforts have been built. So what is data to care? Well, the definition, and this comes from the cdc.gov website, is it's a public health strategy. So it's definitely based in partners of our public health partners that uses HIV surveillance and other data to support the HIV care continuum, and can be used to identify persons living with HIV who need HIV medical care or other services and facilitate linkage to these services. And the CDC actually urges jurisdictions, these are health department jurisdictions, should include the active use of HIV surveillance as part of their comprehensive strategy for linkage to and re-engagement in care activities. And they further say that programs that currently implement data to care, this is the abbreviation D2C, have shown improvements in their surveillance data quality, better collaboration among surveillance, prevention, and care and treatment staff, as well as successful linkage and re-engagement for people living with HIV. So those are the potential benefits. So what are examples of data to care activities? So this is really within the HIV context. So for example, if the surveillance can be used to identify persons who are not in care, people conflate not in care with out of care. There's a lot of different lingo out there. And then linking is really more towards people who are newly diagnosed, linking them or re-engaging them in care. It can also be used to identify persons who are in care, but they're not virally suppressed. So can we just call out those people and then get their providers to create a plan to get them to be virally suppressed? And another way is to identify pregnant women or mothers and their exposed infants who may need coordinated HIV services. So what are the potential benefits of D2C programs? As I've already mentioned, you can improve successful linkage or re-engagement in care. You can expand partner services for people with HIV who are not even not newly diagnosed, including re-interview individuals who are out of care, identify and follow up with people who may be non-virally suppressed. It can also be used to improve surveillance data quality, because when people find people who are out of care, for example, they can let the health department know, hey, by the way, can you update your information? So it can improve surveillance data quality. But I think an important component of data to care programs is you get people from surveillance, prevention, care, and treating staff. You actually get them talking to one another as opposed to being siloed. And that is actually a very important aspect of these types of programs. Okay, so if you look at the National HIV Strategic Plan, a roadmap to end the epidemic, again, this is the 5-year plan from 2021 to 2025, these are the goals. I don't need to articulate this again because everyone knows this who's in this group. But if you look at the document of this roadmap, and you look at the prevalence-based HIV care continuum, this was 2018, which is more recent than what's published by the CDC. It's 56% of people who are diagnosed with HIV, 56% of people who are living with HIV, whether they're diagnosed or not, 86% are thought to be diagnosed, 56% are virally suppressed, and then 50% are retained in care. We know that this is problematic. And why? It's because if you look at this other table about modeling of who's responsible for HIV transmissions in the United States. So for people who didn't know they had HIV, okay, they account for 38% of new transmissions. People who knew they had HIV but weren't in care accounted for 43% of transmissions, and people who were in care but not virally suppressed are 20%. So, this issue of people who are not retained in care, not virally suppressed, continues to fuel the HIV epidemic. So the basic concepts of the data to care strategy are outlined here, and this was shared with me by Heather Leonardos of our Connecticut DPH. She heads up HIV surveillance, is really identifying people who are not engaged in care, using their viral load, because this is all part of surveillance, to determine their care status, and then use these data to inform how can public health help in follow-up. Okay, so this brings us to our study.
Villanueva from Yale University School of Medicine.
So we had a CoRECT. That was a part of a slide for Croy that had a voiceover, and I forgot to take out the voiceover. So I want to just talk about our CoRECT grant, which stands for the Cooperative Re-engagement Clinical Trial. And there were 3 sites for this grant. There was Connecticut, there was Massachusetts, and there was Philadelphia. Okay, and this was a CDC grant that was used with a randomized controlled trial to look at a data to care approach to people who are out of care for HIV in these 3 different jurisdictions. So Connecticut was chosen because we had quite a number of cases of HIV, and then we also wanted to focus on 3 counties in New Haven, in Connecticut, Hartford County, New Haven, and Fairfield County, because these account for 85% of HIV cases in Connecticut. So I'm going to first talk about our data from Connecticut, and then I'm going to expand out to the multi-site data, because we were all kind of different. And I'd love people's inputs as to, Massachusetts and Connecticut and Philadelphia, even though we're all in the Northeast, we're like all quite different. So I wanted to sort of say that as a preface. Okay, so who were the partners in Connecticut? So of course we had the Connecticut Department of Public Health, and they were actually the grantee of record. And the person who was leading the HIV branch at that point was Heidi Jenkins, who has since retired. Then she had under her the HIV surveillance team, and then the disease intervention service, which were, these are called the DIS. These are field workers who are charged with going out in the field to find people who are designated in this grant as people who are not in care. So we at Yale were responsible for being sort of this outside group who were looking at it from a sort of an overview to develop the intervention, to do the study design, to do the evaluation and the data management. And we had 23 participating clinics in Connecticut, of which 18 were Ryan White clinics, 4 were private clinics, and 1 was the VA. And the reason I want to point out that Yale being involved in this arm, it was actually very unique in the way that this program developed, because Philadelphia and Massachusetts had no academic partner, okay? They just did it. They're the health department. They're going to do it all, okay? And why did Yale get involved? Well, we wrote the grant, and we kind of, encouraged the health department to become part of this initiative, because at that time, when we wrote the grant, they felt that they didn't have the expertise to carry it out. So that's how Yale came in as an academic partner, which has its pros and cons, but I'm just stating that at the outset. Okay, so the first thing is, how do we define out of care? All right, so I'll put this up here. So the way we define the out of care is very important. Okay, before we even get into the surveillance, we have to define who's out of care. And so for purposes of this grant, all the sites were asked to say the people who are defined as out of care had to have evidence of being in care for 12 months, followed by 6 months that they were out of care. Okay, and in care is defined by, did they have a viral load or a clinic visit? And being out of care means, did they not have a viral load, or they did not have a care visit? Now, we allowed a 1-month lag because of data being slow, but all of these, once we define this group of people through surveillance and through the clinics, then there was a case conference where the DIS, this is the health department representative, and the participating clinic would powwow, and they'd say, well, who do we really are worried about? So they were allowed through this case conferencing to exclude well patients, because if they're well, they just happen to not get a viral load in 6 months, but we're not worried about them. We don't want to have DIS go after them. Okay. Then if they had a recent visit that fell in the lag period, if they had a visit scheduled in the next 3 months, that is, this patient is really, they're not really lost to care. They're coming in 3 months. We don't want a sick DIS on them. And then, of course, if they were incarcerated or they moved or they were deceased or they were not our patient, and certain issues of provider discretion, the clinic was allowed to say, do not randomize them to go to the DIS. Okay, so this was our definition of out of care. And so the whole idea is that the health department has surveillance information. The health care providers have their information. We in the clinic are very close to our patients, and we have information about them before the health department would know about them, for sure. And so it's by this sort of case conferencing strategy, which is really going to be able to define who's truly not in care and who are we really worried about. Okay, so this is not a trivial process, let me tell you that. But many data to care programs in the past have just said, let the health department do it all. And then the health department would go out there and they'd find people who were like, they're not worried. Why are you worried about me, right? So by having the clinic input, it really creates a list of people who we consider are truly not in care. Okay, so hopefully that makes sense. So we thought that the investment in time by having the clinics come into the picture was worth it. Okay, so this is our methodology. Here on the right is really our clinics. We had them, many of you are familiar with these different clinics. There were 23 HIV clinics in Connecticut. And the study design was a randomized controlled trial. Within each clinic, we would randomize to either the clinic standard of care, which is what does the clinic do already for these people who are defined as out of care, versus the DIS. These are trained field epidemiologists. They're trained in the health department, and they were trained to facilitate re-engagement in care. And again, I went over the eligibility of who was eligible for this randomized controlled trial. Our data sources were the Connecticut DPH-EHARS, that's the hallowed HIV surveillance database, and then client level data from our 23 different clinics. Our recruitment time period was between 2016 to July 2018, and we followed them up for up till February of 2020. We had 3 primary outcomes. That these folks were randomized was re-engagement at 90 days, as stipulated by was there a viral load in the system, retention and care, retention and care, that is, did they have 2 HIV labs 90 days apart at 12 months post-randomization, and then viral suppression, less than 200 copies per ml at 20 and 18 months post-randomization. Okay, so those were our outcomes. So this is a very busy slide, and I know my data manager, Janet Mycelli, is on the call, on the line today, and thank you to her for following all of our data. But just to show you that data to care is complex, okay? And it's not for the faint of heart, but once you get it going, it becomes systematic. So as we said, we identified who are the in-care patients for 12 months, followed by who has out of care because of the 6-month out of care time frame. And then the people who are eligible were those we call potentially out of care. I won't get into the details. These were people who didn't have any markers of being in care for 6 months. And so that was 2,958 people. We took those people to case conference, which is with the clinics, and we let the clinics say, are you worried about these people? And they said 499 were actually well, we're not worried about them. 946 already had a recent visit that the health department surveillance missed. 398 had an upcoming visit. We put those on a watch list. And then a whole bunch of other people were already deceased. They were residents of ECFs, et cetera, and that left us with 624 who are potentially randomizable. Then people who were in this watch list, we added them for randomization. At the end of that time period, we were able to randomize 655 people who looked like they were out of care. So the first point is that a lot of people who the health department would think they're not in care, when the clinic weighs in, actually there were only 22% who the clinics were actually worried about. So that actually cleans up the out of care list quite a bit. And of these 655, 333 were randomized to the DIS, the field epidemiologist, and 322 to the standard of care. And so what we found in this is that, again, just the first lesson, because these are lessons
Well,
learned.
congratulations. That sounds like a really successful enterprise, and reflecting the hard work that went into it, and the quality of the network.
Thank you, Stan. Thank you so much, Stan. But one of the things is that really when we keep looking at our continuums of care, not that we should have a rosy look, but when the clinics weigh in, this is when we applied what we found to the Connecticut continuum of care for 2017, which was the time frame, we actually found that a lot more people were in care. And so that in fact, if you add those in care people to the list, the number that are out of care is actually not as much as you would think. So that in fact, 92% by our calculation are retained in care, and actually maybe only 8% are not retained in care, and that's a much lower workload for people to find. Okay, so that was our first lesson. There's actually fewer out of care once you refine the data. Yeah.
Ditas, this is Jen. That's a great problem, right? To have that surprise that more are in care than anticipated. Thank you for sharing this. Just going back to this prior slide, when you talk, are you going to talk more about the case conference and how that happened and the mechanics of that? And
yeah, I'll get into that in a little bit, because that is actually an important thing that should be highlighted.
Okay, thank you.
Okay, so what were our results? Okay, so these are the primary outcome results by intervention arm in Connecticut. Okay, so re-engagement in 90 days. Okay, so the DIS were 51.1% were re-engaged at 90 days versus 41.9% in the standard of care arm. So that was statistically significant. So that was the finding that the people randomized to DIS of this what I call truly not in care group were successfully re-engaged by the DIS. So the DIS outperformed the standard of care. Then when we wait longer, so we look at what happened to the people who were randomized, okay, at 12 months, there was no difference in the standard of care versus the DIS arm in terms of retention and care. There was no difference in viral suppression at 12 months and no difference in viral suppression at 18 months. So the only statistically significant difference in these two arms was re-engagement at 90 days. By the way, the groups were very well matched, so the randomization worked. And so the question, of course, is why is that? So I think that, you know, one of the speculations is that the DIS are very good at sort of charging people up, finding them, what are your barriers to care? We'll get them in, okay? But then they're off the grid. Then it's up to the clinic, right? So we're back to the clinic has to be, you know, charged with retaining people in care. But the DIS are a good arm for galvanizing this. So I think that that's one of the things that we learned. Now, okay, so how about the multi-site? So so we were in Connecticut. So this was a paper that was submitted by our lead project officer at the CDC, who was Robin Fanfare, and they had all of us, and from our group, Rick Altice was also involved with me. I don't know if he's on the call here to be able to comment, but this was really led by the CDC, and the major partners here were Philadelphia, and their lead is Kathleen Brady, who many people may know, and in Massachusetts it was Alfred DiMaria, who were also involved in this effort. And so the demographics of the multi-sites, I'll just, you know, overall 1,893 people were randomized, and it was, you know, 50, more or less 50-50 to the DIS intervention to the standard of care. Both groups were very well matched, predominantly male. These are the folks who are out of care. That every group went through the same process. It was heavily African-American group. The median age was about 46 or 45 in both groups. The major transmission category was in the MSM category, followed by the injection drug use. And then when you look at I just selected a few of these statistics in terms of characteristics, but when you look at, you know, the folks who were randomized, 75% had a viral load undetectable in the year prior to randomization, okay? And, you know, 50% of these people who were randomized actually had T cells of above 500. 21% had T cells of above 350. So what I'm saying is that the first comment is that, did we pick the right group? They did look like they weren't in care, but they looked like they were not bad, at least in the year before. Their viral loads were not bad. Their T cells were not bad. So this looked like a relatively preserved group immunologically and virologically. So I would argue, and we'll show the data, is that it's actually a good group to go after, because you don't want to go after them when they're like in really bad shape. So, you know, we do this in medicine. Are you sick enough to get care? Or are you too sick? So I think that just this particular strategy looked at people who were newly out of care. So they were in care for 12 months, and then something happened in the next 6 months, and they kind of fell off the bandwagon for a little bit, but they were not like in terrible shape at the time that they were in care. So what did we see for all the 3 sites? Okay, so this combines all of the 3 sites. So for all 3 sites, re-engagement, overall, the intervention, this is the DIS group in the black, about 55% re-engaged at 90 days versus the standard of care, which was 42%, which was statistically significant. So just like in Connecticut, Philadelphia, and Massachusetts, we all had the same experience. The DIS group was better at re-engaging people by 90 days. But how about retention? Okay, so I already told you that Connecticut did not show statistically significant change, the DIS group, but this is almost statistically significant for all the groups, but not quite. So again, for all 3 sites, overall, the DIS group was not statistically significantly better at retaining people at 12 months. And then this was viral suppression at 12 months. Again, not statistically significant when you took all the 3 groups. But I want to point out that one group, Philadelphia, had statistically significant retention in care. And I'll just preface that by saying they got their case conferencing methodology down to a science. So this is what Jen was getting at. What did the case conference look like? I can tell you, Philly ran fantastic case conferences, and I think that made a difference. Okay, so let's look at a little bit more time to re-engagement. So all the sites had better re-engagement at 90 days. And this is just a Kaplan-Meier group of the intervention. This is the DIS in blue compared to the standard of care. And clearly, you know, this is the probability of not re-engaging. So this is a little flipped backwards, but the correct intervention, the DIS, clearly the probability of not re-engaging was better than the probability of not re-engaging for the standard of care. Then if you look at, you know, time to viral load suppression, even though as a group, you know, the DIS did not outperform in terms of viral load suppression at, you know, at 12 and 18 months, the time to viral load suppression between the 2 groups did differ. So, and that was statistically significant. So for all the sites, you know, the DIS group, the intervention group, the median time to viral suppression was 78 days versus 100 days for the standard of care. And again, you know, for Philadelphia, when you look at their site specific, they were very statistically significant. This was statistically significant because of Philadelphia, to be honest. And so when you think about that as a lesson, it's like, why does it matter, you know, to re-engage people? Because the DIS actually, you know, when time to viral load suppression is decreased, that's better for public health, right? People are suppressed in a shorter period of time, and that's a good thing. Okay, so the conclusion of sort of all of this is that the data to care process, which involves joint data sharing and evaluation between HIV clinics and the DPH it was a hard, you know, thing to do, but they did successfully identify PWH who were recently out of care and eligible for the DIS intervention. The data to care process actually refined the continuum so that we could better quantify who we really thought was out of care, which I think was important. The DIS were successful in re-engaging the out of care PWH at 90 days, but not in the longer term outcomes like retention and care at 12 months, viral suppression at 12 and 18 months, because the standard of care group eventually caught up with time. Okay, so the DIS sort of like were the jump starters, and then the standard of care group eventually caught up with time, but that could be at a cost, right? I didn't show this data because I didn't know if I had time, but re-engagement in care at 90 days by any means. So we looked at re-engagement, whether it was by DIS or standard of care, because re-engagement at 90 days is generally a good thing, whether or not it was because they eventually re-engaged or because the DIS jump-started the process. But the folks who re-engaged by any means were more likely to retain at 12 months. So that's important. So whether the clinic does it or whether the DIS do it, just getting them in at 90 days makes it more likely that they're going to be retained at 12 months. But there's still gaps, because not everyone in this group re-engages or in care. So it's, even though, the DIS jump-started things, we still have people who were not even amenable to any of these interventions. So how about additional lessons learned? So these are include the data cleanup is very resource intensive. And so anything we can do, and there are thoughts at the health department about how to do this, is can we have a more efficient data infrastructure? And I won't get into that because that's more in the informatics side. And so, but there are talks about that. And I can say that in Philadelphia and Massachusetts, their data informatics, and I've talked to other health departments, for other reasons, and the informatics substructure in various health departments are increasingly more sophisticated. This is what Jen alluded to. What is the role of that case conference for determining truly out of care? So this was formalized by Philadelphia, and what it is that it's a telephone call that is structured. So every month or every quarter, each clinic will meet with the health department representative, and they go through like a checklist of things that they want to know about the people who have been identified as out of care through surveillance. And they just go down the list, and it's a checklist. It's very easy. And then at the end of the list, they have the plan for who's going to be, who the DIS are going to go after. And so I think that, we were not as good about this in Connecticut. And I have some, theories for why that's the case, but I can tell you that Philadelphia had a track record for doing this kind of work even before this grant, okay? And so that they had many more years to sort of hone this process. And in the beginning, because we had 23 different clinics, we were sort of like, can we do case conferencing for all these 23 clinics? And we didn't formalize our case conferencing methodology until a little bit later in the grant. So, but this case conferencing, as I've worked on other projects, is that important link where the clinic talks to the health department, and that concept cannot be underestimated. I already told you the case conferencing was critical for whittling down these number of out of care cases, and that's less feasible with surveillance only strategies, and it modifies the estimates of out of care. And what that can do is then the DIS do not have to be looking for so many people, because they can hone their efforts on the people that the clinics are concerned with for out of care. Now, there's this whole issue of optimizing the time frame for out of care. So we were told by the CDC we had the 6-month out of care time frame, but we actually looked at other time frames. We looked at 15 months and we looked at 18 months. And of course, fewer people are out of care for that long. Okay, so you say, oh, that's great. Those are the people that we should focus on. But the honest truth was, these folks have been out of care for such a longer time period, the DIS could not find them. It was much harder to find them. And a lot of these folks, they were in much worse shape in terms of their CD4 counts and their viral load. So the question is, did we wait too long, right? Yes, there were fewer people in this group, but they were in worse shape. And so I would argue that the longer time frames did not serve this process well. So I can say the shorter time frames, the 6 months, which we did in this grant, you have more cases to sort through, but you have a higher success in finding them. And then the people have potentially, they're not their CD4s and their viral loads are not so bad that you actually can prevent transmission, because you're getting them to be viral load undetectable in much faster fashion, and you're getting them before their CD4 counts are like out of whack. So I've argued to our health department that we should maintain the 6-month time frame, and Massachusetts and Philadelphia have maintained the 6-month time frame, but we're still undecided here in Connecticut as to whether or not we have the workforce to maintain the 6-month out of care time frame. That's what I favor based on what we've learned. The other important thing is the role of the DIS, okay? They're trained, all DIS are not created equal. And I can tell you that in Connecticut, we had one DIS who was less engaged, shall I say, in the process, and that person's re-engagement statistics were lower than the other 2 DIS. So it really matters that the DIS are held accountable. And the other thing, lesson learned in this is that because we at Yale were collating the statistics and we did not employ the DIS are health department employees, we had less leverage in terms of accountability for the DIS. So I think that's another lesson learned. Massachusetts and Philly did not have that problem because they're getting the data and they are holding their own DIS for accountability. And I'll move on to the final lessons learned is that designing and sustaining a data to care program can be challenging, as you need committed leadership to continue to build and adapt the infrastructure. And optimizing the partnership between clinics and health departments can be the subject of further research. I think there's a lot of room to explore that. I think that since we were the only site to include an academic partner, we can provide the research expertise. The other health departments, while they were much more nimble in terms of implementing the data to care, they were less inclined to try to publish their results because they're much more like, let's get this work done. And so we were a little bit different in that particular goal. And so that may have been a pro or a con. So I just wanted to end, I had other things that I could talk about, but I just wanted to limit my remarks. This was the team that led us in Connecticut, Heidi Jenkins and Sue Spears at the health department. These were our 3 DIS who were much more computer savvy than other people, and they were very good at finding people. And this was our team here at Yale. And I just want to thank everyone who participated in this project. So I'm going to stop my share, and I think we have time for questions.
So DIS, thank you for sharing that beautiful presentation, all that work. Congratulations on all that you guys have learned. There are a couple of questions in the chat, but I'm going to start with one, if that's okay. And it's similar to what Jerry asked regarding the characteristics of those who were brought back into care or lost to care. Do we know anything further about them in terms of their risk, homelessness, and what prompted them to be out of care? Was there anything that came up that you know about?
So thank you for asking that question. I didn't put all of that up, but I can tell you because I've been reviewing this, and Janet, you can comment. So we looked at the people who got re-engaged and the people who are not re-engaged. And the only difference between the re-engaged versus the not re-engaged was really, the major was age, okay? The younger people tended to not be re-engaged, okay? And that continued to be a theme, honestly. But there was not people who were, there was not a racial predisposition. It's not like African Americans or Hispanics or other groups or even transmission risk factor. It wasn't like MSM were less likely to re-engage. So re-engagement seemed to be an equal opportunity thing, except for the fact that the younger people seemed to be less likely to re-engage at 90 days. And in terms of homelessness, we did not have that data, unfortunately. We also didn't find the difference between people's mean viral load or mean CD4. It's not like people who had lower CD4s were going to be more re-engaged because they're in more trouble. It really, the only thing that panned out for re-engagement was age.
Was there any insurance information?
We did not have insurance information. Actually, you know what? I'm going to show.
We had some insurance information, but I think a lesson learned was DIS are not great for data collection. And so we weren't really able to glean a complete data set about insurance information for their visits returning to care. Another thing I'd like to mention is we did, again, have the DIS collect barriers to care information. So for the folks who we actually were able to engage with at some level, the folks that the DIS got to talk to any degree, they would kind of assess needs if they weren't clearly informed by the participants, by the patients. And really, it seemed like the overarching theme was life happens. You know, I forgot, I couldn't get off of work, that kind of stuff seemed to be the biggest barrier. Sure, we got a few people who, said, well, I've been, using drugs and haven't been taking care of myself, or, alcohol. I have other things to worry about, but it seems like the major barrier was, things related to just life of, the same reason that we would forget a physical. It didn't seem to be really related to more severe circumstances.
I was just going to ask.
Yeah, I think that's really an important point. But the problem is that, we didn't get everybody to fill out the barriers to care survey. And so that became, a limiting factor. I think that, that's the kind of qualitative information that the health department can't necessarily get. They can't give us information on, substance use habits, or they can't give us information on homelessness. They can't give us information on insurance status. They can, give us basic demographics. And that's why we know that the age was a predictor of not re-engaging. But the cohort from which we were able to get these barriers to care, that's what they told us. It wasn't so much like homelessness or active drug use, but maybe those were the people we couldn't find, so there's a sampling bias.
May I ask, what about incarceration? Were any of these people lost because they were incarcerated, or did the Department of Health look at that?
So we excluded that because we excluded incarcerated people in the people who were randomized. When they did the case conferencing, if you were incarcerated, you were not eligible to be randomized. So the people that were left to evaluate were not incarcerated. So that wasn't a reason for re-engage. We took those people out.
Okay.
There would be no way for the DIS to really get them into care. And hopefully the DOC was taking responsibility for them,
I was just thinking, because of younger people and what we know about who gets incarcerated, or even just in jail rather than in prison, might make a difference in terms of escaping the net that you carried out or threw across the state so well. It's a very amazing and impressive piece of work. I thank you. I wonder if you look at the national figures and you look at what we think about when we see all the CDC data about who is retained and what percentage and all, do you think there's a lot of heterogeneity then in different states and in different ways in how the data actually is collected? So it's not uniform across the country, although we look at it as a national sort of, outcomes.
Yeah, no, I think, and I've talked to Laura Cheever, who is at HRSA, about this, and she says, the CDC is the surveillance capital, obviously, and they have to define everything in uniformly, and that's the way they do it, right? But the whole case conferencing methodology, and there's clearly differences from one state to another, but the CDC has guidelines for how you create your HIV care continuum. I've looked at them, and Sue Spears follows it to the T, okay? And it's strictly based on surveillance, but inputting this clinic knowledgeability into it is really critical, but that is so much harder to do. But she acknowledges, Laura Cheever acknowledges, she goes, we know that the those who are not retained in care are overestimated.
Yeah,
So,
that's why I asked, right, that they may be in care, but yeah, exactly.
yeah.
So Daniel had a question going back several slides, was what would be too sick to re-engage in care mean? So I think something you're thinking of articulating, Judith, is like the individual pre-diabetes or pre-DKA as opposed to the patient in DKA is what came to mind for me, but maybe you want to respond to Daniel's question. What does too sick mean?
Wow, I'm glad there are other clinicians on this call. You know, too sick is clearly the people I see admitted to Donaldson and they have OI. That's clearly too sick. And when people, and so the issue really is that, you know, I think as a clinician, seeing people serially, okay, and not just like, oh, your CD4, because the CD4 and the viral load, they are far too late to tell you how well or not well a person is doing. It's really kind of it's a surrogate, and it's obviously what the health department can do. But I find that when I see my patients and they say, oh, my T cells are not that bad, but I'm looking at their viral load, I'm looking at, you know, you haven't had your mammography or you haven't had your PSA. So I think one of the lessons is that it's not all about HIV parameters. It's like, you're too sick because you haven't done your screening, okay? I have had too many people who now have, you know, cancer, okay? And you fell out of care because you thought, oh, my HIV is not my problem, but you've had all these other issues that have come to the fore. And so one of the things is that I do think getting people into care just on a regular basis in a continuous fashion for more than HIV is really the right way to go.
Yeah, so I completely agree. And I think, Daniel, to your question, it's never that you're too late to re-engage, but there can be a missed opportunity if you're not engaged continuously, right? So I think that's just the point.
And I do think, Daniel, too, that, you know, I do know when people, I have so many examples of people who, like, where have you been for 18 months? And then their T cells have plummeted and they think, oh yeah, well, we can get them back up again. I can tell you, when people are sicker and they're older, I can't get their T cells up. So I do think, you know, from the clinician standpoint, too late is really when people's health starts, you know, there's a signal that things are not good. And sometimes a lot of it is that I'm just watching you and you don't, and there's many things that are off kilter. Mike Verada, you had your hand up. You wanted to input.
Yes, thank you. And that was a great talk. Got a lot of information from your study. And of course, we were part of that as well. So I'm familiar with the process of communication. But I was just wondering, from all of what you presented and sort of the lessons you learned, what sort of solutions or did you address any kind of way of approaching some of these problems that you faced? And just wanted to add, so recently we had a regional meeting for all the Ryan-White groups in the Northeast, and met with HRSA, and Laura Cheever was actually on the meeting asking about sort of what kind of approaches have we done to try to engage people back. And one general theme was that technology is a big piece, and that we need to work on sort of improving technology. And the examples given was that some regions were handing out telephones, basically, you know, and to their clients, or tablets so that they can keep in touch. And I guess part of that in what happened through COVID was that you think telehealth would be another way to re-engage people into care. Thank you.
So thank you for that comment. I was saying earlier before this talk is that the DIS as an intervention, we're talking about DIS here in the context of HIV, but DIS as a field arm of the health departments in general have really gotten a lot of press because of COVID, because COVID trackers are kind of DIS, right? So DIS training is something that can be utilized in various other contexts. And we've looked at it for hepatitis C, we've looked at it for HIV, but the original was HIV and actually, you know, contact tracing for STDs. So one of the things is that under the Biden the rescue plan, okay, they infused actually a lot of money into the DIS effort, okay? So the issue is the DIS are seen now, increasingly seen as a benefit to health departments. But how the DIS work is what you're asking, is that, okay, now we got the DIS, so how do we mobilize them in a very effective manner? And I do think that that's really where, you know, in this grant, it was face-to-face, okay? The DIS are gonna find these people, track them under every nook and cranny. I'm telling you the stories they told us. They would attend, they'd go there on Sunday after church and they joined the whole family finding I mean, they went through all great lengths to find these out of care people, okay? Can we not utilize technology in a better way? I think that is the future, because it's not so cost effective for these DIS to be marching out there, you know, and they had creative ways of finding people, but I do think people are more into the telehealth technology, and why couldn't the DIS capitalize on that in a more efficient way? People are more expecting that. So I think that's an area for research, actually. How can we, because the DIS, you know, they're not healthcare providers. So they're not like in the clinics where we do our telehealth visits the way we do now, right? They're like, how do you script that? So they call people, but they, you know, they call people, you know, the DIS have been doing syphilis tracing forever and a day. They call people, right? So this is their bread and butter. I think they just need to, you know, adapt this for HIV out of care. And there may be a better way that we can help with.
So it may be helpful, since the people who are out of care are weighted towards young people. And young people are the ones who can actually use the technology.
Yeah, I think that's you know, I'm not one of the young people who are the DIS. These guys are savvy, and they could. I think we could utilize some other technologies that are more spiffy, frankly. You know, because the way they would re-engage them is they would find them and they'd say, "What are your barriers?" You know, they would do motivational interviewing, which are all tried and tested and true. But I wonder, is there a different way to motivate, particularly the young people?
I have a comment. This is Loretta.
Hi, Loretta.
Hi, DIS. I tried to raise my hand, Jen, and I'm sorry I wasn't able to. I don't know what I'm doing wrong. But at any rate,
I'm sorry I didn't see it. Go ahead.
You didn't see it because I didn't raise my hand because I couldn't figure it out. Even
you need a DIS person to help you.
There you go.
Or technology assistance.
That DIS, your incredible work, and let me start the video. Your incredible work really dovetails nicely what we found in a small pilot study, and it's qualitative. But I think that putting us both together, we get a fuller picture of, yeah, it's great to have the DIS, but what causes people to fall out of care can often be that there was poor communication or poor relationship with the clinic, the front nurse, the front hall person, or the doctor, that really working on communication skills to establish that relationship. I think it was an important thing that we learned about getting people back into care and kind of rectifying past insults or past perceived insults. Yeah. I just wanted to put in a plug for I think my bailiwick.
Yeah, no, I mean, this is the rich stuff that you can't get out of surveillance. Surveillance is a tool, you know, but it doesn't give you that rich. And one thing, and Janet remembers this, is we would get stories from the DIS. It's like, when you went out in the field, what was it like? I mean, when you finally found these people and brought them into the clinic, what, besides just like, you know, life happens, or some people would basically say, well, you know, no one ever told me that it was important that I come back, you know, at a regular basis. So as clinicians, we perhaps don't even set the expectations of why is it important for you to come into care. They just think, oh, you know, it's just a checkup or whatever. I can miss it.
They'll call me when I need to come in again.
Yeah, they wait for the clinic to call them. And it's like that you didn't get the message that this is really an important continuity health issue. And that just, and particularly for people who are not primarily English speaking, sometimes they didn't get the message that this is your health. And then if on top of that, if they didn't like their provider for whatever, they didn't like the front desk staff, which does happen, they were like definitely not inclined to come in.
I think it's an emotionally fraught disease where there's a lot going on, and where we can intervene and mitigate, risk of falling out of care or promote staying in care through good interactions is very important. I think also the other thing that we learned from our few people, of course, this would have to be tested out on a larger scale, is that, like I say, it's an emotionally charged disease. When I feel better, I just don't feel like I need to go to the doctor,
Exactly.
because you don't want to be reminded, so that's a very human thing that's operating here as well, and that we heard from our participants. With that,
and I know Michael raised his hand, but I do think the clinic owns a lot of this, okay? Because I told you that, the viral suppression and the retention and care were not statistically significant. The DIS did their thing, 90 days, I got you in or I didn't get you in, and then it's a revolving door. Then they move on to the next person. It's never been their job. They're not case managers to keep people in care. So the clinic needs to do a better job. And so part of it is the messaging, I think, is that, you're absolutely right. Some people say, I didn't know I had to come in. Okay.
So Deanie, I think you had a question in the chat. Do you want to unmute yourself? I think this is our last question.
Thanks, Jen, and thank you, DIS, and also your team. So, you spotlighted Patricia Sweeney's paper at the very beginning of your talk, and that just brought back so much memories for me, because we used to have a criminalization of HIV disclosure work group at CIRA, and when that paper was published, so it kind of created like a list of concerns or questions about ethical issues related to how we can use the surveillance data. And then we actually wrote to Patricia and others at the CDC highlighting, these are some concern, and this is how we think we could address this concern. And I just wanted to hear from you and your team members whether there are any lessons learned from how you ensure the data sharing procedures between all the teams, or maybe from the other sites as well, from Massachusetts and from Philly, or how during the connection between DIS and the persons who are out of care, were there any concerns when the process took place? Thanks.
I think one of the always critical concerns why data to care took a while to come in is that people felt that ethically it was not responsible. There was always, and that was stated in the Sweeney paper from the beginning, is that people in the health department were incredibly reluctant because they thought any data breaches would be ethically irresponsible. And so, but then, the question is, and they did all these work groups, is that what are the potential benefits, and would the potential benefits outweigh the potential downsides of potential breaches in data? And so people are very careful about the data. Okay. And I can tell you that, we at Yale because we were the academic partner here, we never got names. Never. Okay. And there was a major firewall. And not only did we say from our IRB, we would not get names, but it was from the health department's IRB. And then they took great pains to make sure that the data transfer did not have names. So it's a little easier when everything is within the health department, because they, as a health department, they are charged and they have the legal right to go after people. If they found somebody with, smallpox, God forbid, then they could go out and find these people. That is the role of the health department. They just added this responsibility on, and partly the reluctance was it's HIV, but they said it's HIV, it's another disease, and it is compromising the health of our citizens. So we should go out there and find people who are not virally suppressed, for example, or who are out of care, because it helps the public health. And they have rights to know anybody's names as the health department.
So I was
I'm
able
I
to
was
view.
just gonna say, I'm cognizant of the time. Sorry, I don't mean to cut you off, but I know we're at the top of the hour. DIS, thank you for a fabulous talk, and to your whole team, and to Deanie and Pete for organizing this. We look forward to hearing more and continuing these conversations. Bravo, so important.
Thanks, everybody.
Thank you so much.
Thank you so much. We will save the chat file and share with DIS after this